over again here. So here we can see that there's an osteochondral injury with the cleavage plane, the separation between the articular cartilage down here at the calcified layer with the underlying bone, where there's been a bone impaction here. And remember, I think we've discussed this before, articular cartilage is very pliable, so if you get an impaction injury, the bone is not. It's very rigid, so you can get impaction fractures of the trabecular bone, which we can see the indentation of the bone here, whereas the overlying cartilage is still intact, but we have a separation at the interface between the two, a relatively common injury, which we can see there. And here we can see the same thing on the sagittal images. So this was an osteochondral injury. John, what was your comment?
On the lateral side, on the first two, the proximal tibial physis, you see a fine line and a fat sat image
over here,
right there, and then on the T1 on the left side, you see a dark line.
Yes.
I wonder if that's an injury.
It could be, but I see that a lot, these little kind of lines here. And I think these are more vascular rather than trauma.
Okay.
And then here we can see another impaction fracture. Here we can see the impacted bone. Notice that the articular cartilage at this point is still intact. What typically happens, however, is now you've got a very sharp, hard, bony margin here underneath the articular cartilage, and over time this will wear away in many individuals, and you'll be left with a full thickness defect here. See, Jennifer, what do you think of this case?
So here we have some images from 2001 as well as 2003. So it looks like here along the tibial plateau, we have a similar appearance where there's some mild interarticular step off, but the overlying cartilage is intact, an osteochondral injury. Looks like there could be also a fracture of the tibial plateau. I can't tell on these two images. But then on the 2003 exam, we can see progressive overlying full thickness chondral loss with surrounding edema.
This was one injury, I think 1701.
Are you sure that that cartilage is in? I mean, the articular cartilage is intact on the. What's that bright area?
Okay.
And
so
and there's a step off on the articular subchondral bone.
So this is the acute injury here, where we can see an impacted fracture of the subchondral bone there. This is fluid collecting in here in the joint space, and we don't really see the cartilage very well right in through this particular area. This is a low field scanner, so we don't have adequate resolution to see it on this study.
I thought the cartilage was maybe a little higher than that. I'm just guessing, John. You guys know more about this than I do.
And then over here on the follow-up, what we see is that that bone injury is healed with a little bit of irregularity, but now we've got a lot of subchondral bone edema on both sides. And this patient went to surgery, and there were full thickness cartilage defects at surgery, though we don't quite have the right spatial resolution on these low field scanners.
I guess so. I was just suspicious there that there is a cartilage defect. I guess I'm over conscious.
I don't know. In these images, I don't think we can resolve the cartilage adequately to know whether it's torn or not here on this particular sequence. Okay, so here's a volume.
Better safe than sorry, though.
Yeah. So
I think it depends on clinical evaluation on top of the MRI, or vice versa.
Absolutely, I agree. So here's a volleyball player that came in with knee pain.
Okay. It looks like there's some signal inhomogeneity of the medial tibial plateau there, and on the lateral tibial plateau, I don't know if there's a depression of the cortex, or if there's some increased signal within the cortical bone posterior lateral tibial plateau there.
So this patient came in acutely with knee pain. It was recommended that they have surgery for the meniscal tear. The patient refused surgery, and actually 4 weeks later was back playing volleyball again without having surgery, and this is what it looked like.
Okay, so now I can see the meniscal tear, and it looks like there's.
Well, actually, it looks like it's healing, doesn't it?
Yeah, I mean, it's less pronounced than the prior, I feel like, but that could just be slice selection. And it on the bone marrow edema is resolved in the posterior lateral tibial plateau, but it does look a little. The subchondral bone plate does seem a little bit depressed there.
So it may be a little bit, but this patient at this point was back playing volleyball again.
John, if you look at the lateral, the sagittal view, there seems to be some dark area there, which could that be a little bit of a depression?
Right, that's what I think Ash, you thought it was a depression in this area too. And yes, he had a little depressed fracture. I think it's healed, but I believe there is a little depression there. This is in the red zone of the meniscus. We know that they can't heal in that particular area, but we never had arthroscopy, so we don't know whether they're actually healed or not. But at this time, the patient was asymptomatic, and this was one of the first cases we had back in 1989 to suggest that the bone injuries may often be the cause of the patient's symptoms rather than the meniscal tear.
Yeah, I would have casted this patient probably.
Okay, so it looks like we have a. Okay, so it looks like we have a osteochondral injury, subchondral fracture of the lateral tibial plateau. There's only kind of minimal displacement.
And this is what Villette and Fowler in Canada call geographic lesions. And you can see there's probably a little depression here of the tibial plateau as well. And the majority of their cases when at acute arthroscopy with these, the overlying articular cartilage was intact, but then when they re-arthroscoped them 6 months later, over a half had destruction of the overlying articular cartilage. So these, we believe, are high-risk lesions. Okay.
That would look normal on arthroscopy.
On their study, the initial arthroscopy, the cartilage looked normal. Follow-up arthroscopies, and
I don't think you'd be able to really see that with the scope without doing some damage to the articular surface. The meniscus is right on top of that area. You'd have to go underneath it, and that's a tight area right there.
Thanks, John. So here's another patient who came in with classic signs of meniscal tear, but the MR scan showed this geographic subchondral lesion. So the arthroscopy was canceled in this patient. They followed them, and the patient's symptoms resolved without having surgery. Okay, this was also NBA All-Star player back in the 1990s. Jennifer, what do you think is going on here? This is a T1 weighted image.
Okay. So there is diffuse decreased T1 signal intensity kind of along that medial femoral condyle. So I'm wondering if they had acute subchondral injury or contusion. I'd like to see the T2 images as well.
He was kneed while going up for a layup at an NBA game and came down on it awkwardly. I don't have any other sequences at this time. What they showed, we didn't see any articular cartilage or meniscal abnormalities at this particular time, just this area of bone abnormality. This was before we had fat suppressed images, so we just had the T1 and a T2. And you can see a little bit of increased signal intensity on the T2. And then here he came back 4 weeks later. He was still symptomatic. What do you think?
Okay. So now we can see some depression of the subchondral bone plate and some overlying full thickness chondral loss. So it looks like an evolving osteochondral lesion.
What happened?
What do you think the prognosis is right here, Jennifer?
Well, these are at risk for epiphyseal collapse. They definitely need to be followed. In the beginning, when he had the initial injury, he should have been placed non-weight bearing at that time since he did have the subchondral injury. And since the surface is so irregular, there's also risk for surrounding progressive full thickness chondral loss and worsening degenerative disease.
So now a lot of the bone marrow edema, at least on the T1 weighted images, is resolved, and we can actually see the underlying subchondral bone with better contrast, and we can see there is a focal defect here, and we can clearly see on the T2s there's fluid going through a full thickness defect in the articular cartilage. This is a gradient echo sequence where we really can't see any of these changes. This is back when people were toying around with gradient echo sequences, and it's one of the last ones we did. And then he came back a year later, and this is what it looked like.
Okay, so here we have this chronic osteochondral lesion. It looks like there may be some cartilage now. I wonder if he had a procedure.
Yes, he didn't have a procedure at that time. There really weren't a lot of cartilage procedures back around 1990. This just shows, well, before the margins were pretty sharply defined. Now the margins, it's a little widened, the margins a little bit less distinct. This is just kind of progressive degenerative disease in the area of the osteochondral injury. And he came back and tried to play the next year, but was unable to play again. Okay.
Okay, so 59-year-old with new onset knee pain. Looking at the medial femoral condyle, we see extensive bone marrow edema of the subchondral bone. There's actually some irregularity of that subchondral bone plate, I think. The overlying articular cartilage, I can't really discern, but I think it's intact. But I would definitely be non-weight bearing. I think there'd be concern for progression.
Well, he did not take your advice. And this is what it looked like a few months later.
And now you can see that the subchondral bone plate, I think, is fractured. It's a little bit angulated, and there's focal edema there.
So what would you tell the patient on that last case, this 59-year-old?
Well, if they've already progressed to this state, I think you still see that the bone marrow edema is there, so there's risk for further collapse. And so I would still keep them non-weight bearing, and try to see if there's some resolution of the bone marrow edema and see how it heals.
Well, you might try to do arthroscopic picking, but 59-year-old, it's almost a toss-up. You might think about medial compartmental replacement, but lateral replacement. I think
Medial.
I would do a little picking to try to save it. Not that big a procedure, and pretty good results.
64-year-old male, 2 weeks pain after hearing a pop 4 months after surgery. Okay, so we see a kind of a large subchondral osteochondral defect in that medial tibial femoral condyle. There's pretty much no cartilage and depressed defect. I'm wondering if that's all depressed or if there's actually a fragment somewhere. Joint effusion, and then there's a big popliteal cyst.
I don't remember whether there was a loose body anywhere. That's certainly something you'd want to look for. And you can do osteochondral grafts in a situation like this, or medial resurfacing techniques which occur. So a number of possibilities here.
Do we have an age on this, John?
Well, this was not present at the time of surgery 4 months ago, so it's relatively recent.
So he's 64 years old.
Right.
Well, then that's an easy choice.
A medial hemicompartment.
Yeah, unicompartmental replacement. They do very well, by the way.
Yeah.
We used to do them in the 70s, and then it went out of favor. And the reason was that my friend who, quote unquote, invented this procedure, Marmer, used 6 millimeter plastic insert for the tibia. Not plastic, but I'm thinking, what is that material? I'm kind of drawing a blank. Age. 6 millimeter was not enough for patients. It had to be 8 and more. 6 millimeters bent too much.
Thanks, John.
And that kind of really screwed up the whole deal and wound up in litigation, et cetera, et cetera. And then the unicompartmental procedures went out of vogue. Last 10 years, they're coming back. I knew they would, but they have to have the right kind of material.
Thanks, John.
So here we can see an acute tear of the mid ACL, and there's a fluid level in the joint space compatible with hemarthrosis. Okay, it looks like there's also oblique fracture of the tibial plateau with some mild impaction.
What is this?
That is is it a Segond fracture?
Well, almost. This is the iliotibial band anterior. So this is actually an avulsion fracture of the iliotibial band anterior to where you get the Segond fracture in that location. And if you go more posteriorly, here's the Segond fracture, which is where the anterior ligament.
So that means ACL is gone.
Anterolateral ligament, yeah. Here's the ACL gone right here, and then here we have the avulsion of the iliotibial band, as well as the anterolateral ligament here, which is the Segond fracture back in here. Yeah. Rarely you can actually get Segond fractures without ACL tears. That's not as common. Pretty rare. Here we can see an avulsion here of the anterolateral ligament, the typical Segond fracture, fluid level in this area. Dr. Granger thought there was no ACL tear. I'm not so sure, but it was intact at surgery. I'm not exactly sure that this might. One of the things that occasionally can happen, it's rare, is you can get a structural injury to the ACL, but the ligamentum mucosum overlying it isn't torn, at which time at arthroscopy, you're just looking at the capsule overlying the ACL and not the ACL itself. But I'm not sure that that's the case here. But
it sure doesn't look intact on the. Well, does it, John?
No, I don't think I would have called it intact.
I wonder if the surgeon was right.
I don't know. Okay, so what do you think of this case?
Can you go to the previous case real quick? And it almost looks like it's another IT band avulsion, but I could be wrong. That second picture, it looks like that's the IT band. Yeah. Okay. Okay. Because it's usually the.
It's like the last one. It's probably IT band
And anterolateral. Okay. All right, here we see some bone marrow edema of the mid-tibial diaphysis, and it's actually extending within the muscle as well, right there. And I don't see a fracture line, so this could be stress injury, stress.
Okay, 69-year-old male, left thigh pain, history of prostate cancer, rule out Mets. See a right hip arthroplasty. So we see area of bright signal on stir, kind of in the subtrochanteric proximal femur, and it's on the lateral aspect, and it has increased radiotracer uptake on bone scan. I mean, this looks like kind of what we were talking about last time. This almost looks like where you get bisphosphonate type fractures.
This patient was not on bisphosphonate.
Yeah.
Those typically start here.
Mm-hmm. It doesn't exactly. It doesn't really look like a Met at all. So, yeah, overuse stress fracture. Yeah.
It does the hip area, John. Does the hip area on that fellow with a stress fracture, not on this view, but the next one that's, is that a total hip replacement?
On the right it is, yes.
Oh, what the hell is he doing getting a stress fracture?
I don't remember the details. In this particular case, I have seen other cases where patients will get a hip replacement and they'll get a stress fracture on the other side because they increase.
Oh, they're putting too much weight on it. Yeah, I've never seen a case in my repertoire. Okay. Sorry. It looks like he's got a good cortex.
Yeah.
All right, so this is reported cellulitis, rule out osteomyelitis, and there's a lot of subcutaneous and muscle edema kind of along the distal tibial diaphysis, but there's also some mild marrow edema and some periosteal reaction adjacent. And here again, we see some edema, increased signal. I think this is concerning for early osteomyelitis, given the periosteal reaction and edema.
I was gonna say that there's not enough edema around there to think about infection.
And the edema with infection almost always centers centrally here, whereas often with the stress fractures, it's subcortical like this. So this is more a stress fracture pattern rather than osteomyelitis pattern.
And you would have swelling outside that bone too.
Yeah, we had a little bit of edema in the surrounding soft tissues that Jennifer pointed out.
Okay, so here we see some edema within the medial aspect of the tibia, and the periosteum looks a little thickened posteriorly.
Lateral aspect of the tibia.
Okay, that was, yeah. I thought it was the medial.
This is a T1 weighted image, so this is bright fat, and this would be loss of the fat signal on the medial side.
Yeah, medial side.
And on the T2 weighted image, what happens is that the fat and the edema are similar signal intensities, so we kind of obscure that. And this is what it looks like on the opposite side.
Okay, it looks fairly normal. Wait.
These are two different patients.
Okay, two different.
So this is actually a bone contusion. You have this increased signal intensity here within the cortex. That's really kind of this was a bone contusion. And this is another case of bone contusion. Here we just have periosteal edema anteriorly here, which is often called Shin splints in these patients with overuse. John?
I was going to say on that last case, I was totally wrong. I was looking at the marrow rather than the outside of the. That's posterior medial, and that's an interesting injury. How do you get away with that without hurting the muscle? I'm not sure I get that.
Well, I don't think it was a direct blow. I think it was just a strain on the bone.
I got you. Okay. So it's like a shin splint.
This one was a shin splint here.
Right.
22-year-old professional hockey player hit by puck the previous night. Rule out medial femoral condyle contusion, which I don't believe we will. There's quite a bit of edema just throughout the entire medial femoral condyle. There's also a lot of soft tissue edema overlying. The MCL looked intact, but it might have a little bit of signal as well. PCL looks intact, large joint effusion. There is a fluid level, so I'd be afraid that there's, that's got to be like hemarthrosis. So there's got to be a fracture, like kind of open fracture to the marrow somewhere, because there's fat in the joint effusion.
Yeah. So this was a fracture, and we never could quite see where the fracture line.
But there has to be something.
Okay, this is a runner with pain. They put a marker kind of along the lateral right ankle. There we go. Okay, so we have decreased T1 signal and increased T2 signal throughout that mid to distal diaphysis with surrounding edema. I think this is just severe stress reaction.
These are stress fractures, but in the parlance of the runner, these are called shin splints. And you often will get edema around the bone, which we can see here, often anteriorly, like we saw in that much more subtle case before. But in more severe cases, you can get this extensive trabecular bone injury as well, which we can see here as signal loss, fat signal loss on the T1 weighted images.
You can see increased sclerosis of the mid tibia right there. I'd be worried about a stress fracture. And here you can see decreased T1 signal and increased T2 signal, and the cortical margin looks disrupted, and there's quite a bit of bone marrow edema there. I don't know if it's just the slice selection, but I'd be worried about a fracture, an incomplete fracture here.
So in this area, the tibia is very interesting because there are a couple of things that can happen here that typically occur in younger age groups. So there's a differential diagnosis that you have to consider here. One would be stress fracture. What would be okay? Another one would be osteomyelitis. A third, there are two more. Okay.
That periosteum is really swollen, isn't it, John?
Yes, it is.
Up and down that tibia.
Yeah. So
that's more than just a stress situation.
Right. So eosinophilic granuloma is one you always have to consider. This is more abnormality than we typically see, but eosinophilic granuloma can have a lot. And then Ewing's, and then another one is fibrous dysplasia, osteofibrous dysplasia, and what's the third one in that category, that group? I'm blanking on the name. Jesus, that's crazy. Well, this is a Ewing sarcoma. Adamantinoma. Thank you very much. The adamantinoma is what I was trying to think of. But this happens to be a Ewing sarcoma, and especially this involvement of the cortex here makes you have to think about eosinophilic granuloma, osteomyelitis, Ewing's, and adamantinoma. In my experience, adamantinomas are the most common of the malignant lesions in this area. But but Ewing's is also a big one in this area. So this was a Ewing sarcoma.
Okay, so it's markedly increased signal within that proximal tibia, kind of throughout the with you're pointing out low signal transverse area. So again, we see all the edema. We see a periosteal reaction posteriorly where there's low signal. There's a little bit of edema within the surrounding muscle as well. So kind of, yeah, again, periosteal reaction surrounding soft tissue edema and edema within the bone, and the sol enhances as well. So I think it's kind of similar to the prior study where you have to kind of give a differential.
With that last case, since you had that transverse fracture, do you also give the other Ewing's and adamantinoma?
Yeah, you have to, because you can get stress fractures in abnormal bone. So you can get stress fractures associated with Ewing's and adamantinomas, as well as fibrous dysplasia. So just because you have a stress fracture doesn't rule out the other diseases. So you have to consider them.
Okay, 20 years old, leg pain for 4 weeks, and he's a soldier. And it looks like he does have some periosteal reaction along the medial tibia and some surrounding edema. I think this is a pretty classic location for a stress fracture. Medial tibial stress syndrome.
These stress-related injuries are all kind of part of the Shin splint syndrome, and with varying degrees depending upon how severe they are. Most people don't use this grading system, so I what I think you can look it up.
Okay. So I'm looking at the right leg coronal view. You can see increased edema, I think, within the muscle of the medial muscle belly there. Or yeah, okay, so it's actually within the subcutaneous fat. There's a little bit of increased signal right there, yeah. And it's just a soft tissue contusion.
So I think the primary lesion really is the bone, but often what you see really are the secondary changes of the soft tissue adjacent to the periosteum, and even sometimes associated fat, probably from some hemorrhage from the microfractures of the cortex, which is what's involved with shin splints. Remember, in the diaphysis of the bone here, almost all the weight is in the cortical bone rather than the trabecular bone. So when you get injuries, it's really more of a cortical bone injury.
Difficult cases to treat.
So outside of rest, which is the last thing these patients want, how else do you treat it, John? John?
Pardon me?
Outside of rest, which is the last thing these patients want to do, how do you treat it? John, are you with us?
Crutches and splinting.
Yeah, right. But you
If they'll follow you.
You have to have a compliant patient.
Yeah, that's the main problem, is to convince them to do that. Boy, I'll tell you, I'll put in a chart all kinds of difficulties to prevent. And you have to, these are cases where you as a doctor have to protect yourself from the legal profession.
Okay. So 49 run with pain for 2 weeks, rule out fracture, stress fracture. So there's quite a bit of edema throughout that mid tibia with overlying soft tissue, subcutaneous fat edema. And the cortex itself and the periosteum looks a little thickened and maybe kind of indistinct. And so I'm just wondering if this is just another case of like shin splints again. Tested Telluride for shin splints? Didn't we talk about it?
Great place to ski.
I thought it was that, you know, instead of bisphosphonates, we were learning about the increased osteoclastic activity of Telluride.
Oh, right. I understand that.
Yeah.
Not that I don't know. I don't know.
So this is a 70-year-old female. This looks like a radiograph of the femur. And there's just some cortical thickening, so I wonder if she may have and some bowing. She may have some osteopenia, and kind of looks like this could be a chronic stress reaction, or yeah. So here we see increased uptake on the bone scan at the mid femur.
Would you say that this goes back many years and getting worse?
I would say this is likely at least over the last few months because she has some remodeling. I don't think it's acute. I'm not sure about years.
Well, you see the other femur bowed, and John is showing us biophosphonate, and she's ready to fracture.
Yeah, right. Yeah.
So, is she already fractured, John?
Yeah.
Yeah, well, she's getting pretty damn close to it.
Yeah.
But she's had problems over the years because of the bowing, and probably had osteopenia or osteoporosis over I don't know how many kids she has, but she didn't take her calcium.
Right.
Here you can see some remodeling of the mid tibia. It kind of bowed there, and you can see overlying periosteum that has separated slightly from the bone. So it's probably healing. Oh, okay. Okay, so assume that's 1-year-old female. So they were born premature. Tachypnic, enlarged PDA. They had a ligation, and then fall down from bed, blood tinged stool known as deception. Okay. All right, so the first, hold on, are those dates flipped? Oh, 2006. Yeah, I was seeing that word. So on the first exam, I mean, so we see there's marked abnormality of that left femur on the follow-up exam in 2007. And looking at that femur on 2006, I don't think I see an abnormality with it, at least not from here. So what could be going on? That looks almost like a calcified like hematoma or subperiosteal hematoma type. Like I think we had a similar one like yesterday. Yeah.
I've seen this case before, but I missed the stomach on this case. Can you go back one slide, John? Look at that stomach. You think there's enough air in there?
They just cry and they swallow air.
My God.
Okay, so this is
Obviously, if you see more than one of these, then you have to think about child abuse in the right setting. So that's important.
so this is a pediatric patient. You can see the physes are open, and it looks like along that distal femur there's some lifting of the cortex and some intermediate signal. So periosteum. So I think this may be another subperiosteal hematoma. Here we can see it again.
Okay, so looks like there's some fragmentation of the medial epicondyle, and looks like there's been some impaction and fragmentation, and I think the distal ulna or the coronoid or the distal ulna is also probably has some edema there, and there's or sorry, proximal ulna, yeah, and then the distal humerus also looks like there's a lot of edema.
We see a little bit of fluid here. Growth cartilage here, and then this was an epiphysial injury. Now, the issue here is this is very hard to call because this is one of the last of the physes to calcify in the elbow. So this could just be early calcification. So it's hard on a plain film to know whether this is really an injury or whether this is just a normal calcification. You're just catching it at an early stage. The MR scan here helps us because we could see that there's abnormal fluid within it. But again, this is treated conservatively. And then I think we've already kind of talked about Salter-Harris classification, and I think we may see a few cases of that.
Unfortunately, Harris isn't mentioned often, but Harris did a lot of work in this condition. Salter took all the credit.
I think because of the acronym.
So I see some cortical irregularity along that along the tibial epiphysis. I'm not sure if that's just a slice selection or if that's real. So now I guess I see increased signal within the tibial epiphyseal plate compared, like when you're comparing it up to the femoral. So, you know, I'm worried maybe there's could be and there's surrounding edema, like a Salter-Harris type 1 fracture without displacement.
This is very solid here. You can see a little fluid there. There's a little bit of increased signal intensity all the way across. So this was a Salter-Harris.
Okay. 13-year-old female with medial pain after trauma 9 weeks ago. Again, here there's some increased fluid signal intensity along the physis of the distal ulna, and I'm concerned this may be a Salter-Harris one.
Yeah, some of these can be very subtle. Fortunately, they have a pretty good prognosis, but there's a little bit of irregularity here, which makes you concerned that this could be injured. This is where the pain was. We can see that you're already having loss of the fusion here in the radius, but you shouldn't at this stage see this much fluid going all the way along the growth plate, the little fluid escaping here on the margin. So this is a typical Salter-Harris 1.
So this is a 14-year-old male, pain after a football injury. This is an axial sequence of the knee. First of all, there's extensive soft tissue edema, and we're looking. There's fluid signal extending posteriorly through the tibia there, and also there seems to be a defect of the fibula anteriorly. So, and it looks like that's a Salter-Harris 1 fracture with increased edema. I don't know if it goes in any direction there. It looks actually mildly displaced. Looks like there's some anterior or superior translocation, and it's going through as well. And so this would probably be a Salter-Harris 2.
What do you mean, probably?
So there are a couple of things here. You can see that the periosteum is torn here. That lets you know that it's really an injury. Otherwise, the periosteum should be intact. The other thing you can see here is that the periosteum on the medial side has flipped into the joint's growth plate area.
Invagination.
Right. And then obviously we can see that the metastasis is involved here and the periosteum is involved there. So in the past, when we've talked about these, John has been of the opinion, and here we can see that periosteum flipped in here as well. Obviously, there's been a lot of displacement here, a lot of hemorrhage into the soft tissues. What to do about this? So we've said in the past that you don't want to really go back in and re-irritate the growth plate here, that increases the risk of having fusion, and that these can be left in place. I occasionally get email from different places around the world, and I've had actually several this year that have come in and have complimented you guys on how well you're doing on these lectures. But a number of them have been that there's a lot of people significantly disagree with the fact that this can be left in place. There have been quite a few radiologists and orthopedic surgeons email me saying that these really have to be taken out to restore the normal anatomy of the growth plate. But of those that I've seen in Southern California, I'm not aware of that occurring, that most people have left these in place, and I'm not aware of there being gross disturbances because of that. John, do you want to comment again?
I think age may be important if you're really concerned about this. The older the patient, the less reason to think about surgery. But in this area, I don't think I'd want to stick my knife in there. Okay. And start mucking around with the epiphyseal plate. This is the tubercle region, and that can prematurely close it. It's difficult to work with the tubercle. The tibia, you can take out the bone and put in fat and open the physis up, but the tubercle, that's a different ball of wax. So I would leave this alone. There's been enough trauma already due to the injury. Just think that this tibia was open at the physis and then came back together and pinched the periosteum. That must have been open as wide as that periosteum is long.
Yeah. So right. So I mean, I went along through. So just remember that this is an important finding that needs to be described in the report, but the treatment's significance is still controversial.
Yeah, but the radiologist has nothing to worry about. You call it, you don't treat it. So
right, right.
All right. This is a 12-year-old male with a Splints injury 5 weeks ago. Rule out lateral meniscus tear, and he does have increased fluid along the physis. So this is at least a Salter 1. I also wonder if there may be a Salter 2. It looks like there is some linear decreased signal extending. So this would be a Salter 2.
So I have two Salter 2s. Here's that same patient, and you can see the fracture line.
To go back to the epiphyseal periosteal invagination, you have to remember that there's an injury to the epiphyseal plate, and so anything can happen. You can have premature closure, posterior, anterior, medial, lateral. and you cannot blame that on a periosteum. So, including the tibial tubercle. And so that if anybody says to you, John, that they would operate on this, well, assure me that everything will be okay. Well, you have to remember, once you stick a knife in it, it's your problem, not the patient's, and time. Epiphysial injuries are like that. They can prematurely close at any level. 1, 2, 3, 4, 5 is just more common in 5 and 4 and 3. But you can have a premature closure on 1.
Okay, thanks, John. Right.
Okay, so we see a vertical fracture line basically through the mid-femoral epiphysis. And then we see increased signal extending medially through the epiphysis. So this is most likely a Saltairus type 3, unless, yeah.
Here we see some diastasis along the lateral edge of the tibial physis, and I think there's also some increased signal through the epiphysis of the tibia right there. I'd be worried about a Saltairus 3, and that's what we see here. And there's a little bit of, actually it looks like there might be some, it actually goes all the way through, including, so it's a Saltairus 4, and there's some disruption there. So
this one have a.
What would you do with this?
Send the patient to you.
Yeah, I would call it, and
yeah, 4s you have to fix.
Yep.
You have to put them back on anatomically. 3s you have to watch, because they can become separated. But 4s you almost always wind up operating on.
Okay.
It's pretty hard to reduce them and not operate.
So why don't we stop here, and we'll try to finish out the bone stuff tomorrow, and then John will start on the elbow next week.
Okay, John, by then I'll forget everything I've read.
Well, you'll be in good company.
You know what? The new Campbell's doesn't have much new to tell us about the elbow from the last one.
Okay, all right.
So that's good to know. See you mañana.